Good evening, everybody. Excuse my a little bit lost voice here. This is the hardest week of the series for those who have been here for the last 3 weeks. For those of you coming for the first time tonight, thank you and welcome. Very difficult evening. We understand that. Very sensitive topic. But this is a topic that has been discussed for a very long time. Even the Assesment Rebbe discussed the topic of suicide, and he was going back in the years of 1926 to 1928. During the time of the Depression, and he in Europe, and he was seeing mamish, good, Yirei Shamayim, from Yidden, falling apart. And he goes through a little bit of a capital of what he thinks the reason are. But he also said, I'm also very concerned, mostly, for not the ones who unfortunately have lost their lives, but I'm very concerned for the ones that are still walking around as if they had lost their life. I'm more concerned right now for those walking around internally with inside of themselves, feeling as though they're walking around with nothing to live for. And as he goes through his little thing, he says, the one thing that is the cause and the root cause of these people unfortunately feeling total loss is apathy. Apathy for themselves, and apathy of others for them. One of the things that we have to do, and you know, it's hard to give chizuk on a subject matter of this, but there are things that we can do, simple things. I'll give you one great example, and it's Ben Adam L'Chavero. It's a very, very interesting thought. How many times have we walked on the streets and we pass somebody and we go, hi, how you doing? And keep walking. How often does that happen to you? How would you feel if the person that asked you how you doing actually stopped, turned, and looked at you and waited for an answer? The little things that we can do, not just for ourselves as adults, but those little things that we can do for our children can make all the difference. We are zocha in this neighborhood to have people who mamish understand, to greet, to welcome, to really just get the situation that some of us may be dealing with, and others that we know who are dealing with them. And sometimes people just don't know where to turn. And if we turn around and we say to somebody, how are you doing? How are your children? And you might get an answer of going through a little difficult time right now. And then you can turn around and say, well, if you're having a very difficult time with your childhood, maybe you can go to so-and-so. And if you have to worry about yourself and what you need to know and what for your own as the parent, as the adult, and you don't know what you're allowed to say and what you're allowed to do, there are gedolim in our neighborhood that we can ask the shilas to, and we have one such here tonight. Our Rav Margolis has been understanding the matzav of our children for many, many, many years. He is helpful, insightful, and he's there to help you get through the situation that you're in, or somebody that you may know. Let's end the apathy and really just turn to each other and say, hi, how you doing? And wait for an answer. I'd like to introduce Harav Margolis.
Shkoyach, thank you. You certainly gave me a lot of chizik. I feel very good now. It's a beautiful introduction. A couple of years ago, I was going for a walk I like to walk, and I suggest if you go for a walk, don't take your phone with you. Even if you don't have music, maybe sometimes headphones not plugged in and no one will bother you. And I think that was many years ago in the Vey, the Mash said that. He said it's a new invention. It's not called a Walkman, it's called a Thinkman. Batteries not included. Just put earphones in and no one bothers you because they think you're doing something. And you could think, and you can have a moment of silence, you can have a moment just to have a break. But I was taking my walk, and it gets monotonous sometimes. Maybe try to feel young and boyish, and I saw a cup on the floor. A coffee cup, seemed to be an empty coffee cup, not facing me, I had the closed part of it facing me, and I thought, wow, I'm out here on Nachal Kishon, almost the end, I could give it a nice kick. No one will see. And I got up to the cup, and I gave it a beautiful World Cup kick. And Baruch Hashem, I was okay afterwards, it didn't fall or anything else like that, which would make sense too. And I heard a noise, like a cascading of shells or something. I looked like, what? I thought it was an empty cup. It was full of shells. And an innocent kick, an innocent touch had set off such a reaction. We don't know. We don't know what our neighbors are sometimes holding inside, our siblings, our children. We don't know sometimes ourselves what we're holding inside. And I found that as a very strong message. Before you go in touch, before you go in this, before you go, there's some shells maybe. And it's okay to have shells. Makes sense. Where else would an Israeli put his shells but in his cup or something and then throw it on the floor? Makes sense, yeah? Second story. Several years ago, forgot about that. Several years ago, I was speaking to a therapist from London, a family member. She had gone through mental illness, depression, and it was very, very difficult for her. Not long after, and obviously not necessarily connected, she came down with cancer. She told me, said, Eli, cancer hurts. Cancer really hurts. But my mental illness, it hurt me much more. It hurt me much deeper. Don't belittle the cancer. But when someone is suffering inside, it's real pain. It's real, real pain. We speak of families which have family members which have committed suicide. A brother, a parent, sibling, children. It's a terrible, terrible catastrophe. Death is always a catastrophe. However, for some of us, and for I would imagine most of us, it's easier to sometimes digest such a tragedy. It will take time. There's loss, there's emotion. Every situation is completely unique. But when we come to suicide, it's that much more difficult. Our neighbors don't know how to react. Everyone always looks for a culprit or someone to blame. Whatever, I'm not going to say things. Once my cousin made a wedding. My uncle passed away the night before, and I was there at the chuppah. And we were talking for a moment. He said in Hebrew, he says, Mistaber yesh, it's very hard to be at your daughter's wedding during Shiva. So he said, yeah, there's obviously a lot more stupid people than I ever realized. They all meant well, but it's very, very difficult. But as a community, if we understand, if we accept, if we maybe let our defenses down, then how many people that afterwards say, well, will I be next? Will it be now? Will I blame you? Will I blame that? Why you didn't have? Whatever it is, we could at least give them the decency of treating it like a tragedy. But if we're afraid of the subject, it's that much more difficult to approach it. And I'm not even talking about discussing it with them, just even for our own personal understanding, your body language, your ability to go smile to them might just be different if you understand this person had a tragedy. It's not their fault. And I'll say, from the limited experience, that those that finally did bring themselves to suicide, in most cases, there was a lot of hard work. There was a lot of courage. And we have to focus not on that day that chas v'sholem that happened and they failed or were unable to continue to be matzliach, but we have to look at all those days that they were willing to get up and to do the basic tasks that for you and me are simple, but for them were the hardest possible things. And they had the courage to do that day in and day out. And they lasted as long as they could. And then their illness, unfortunately, was too great for them. Perhaps we could look at their memory in such a way they, to some degree, are heroes. Again, I'm not meaning to heroes. But we have to understand it's a struggle. It's a real struggle. And there's help. And help can sometimes be helpful. We make our ishtadlus. And sometimes we're only human. We're not perfect. I saw tremendous chizuk in the community from community members helping people in these situations, each one of these very unique situations. And I think that the community should feel, they should feel that it's too much to their schus how everybody responded and came together. We shall not judge. We shall not feel guilty. But beautiful evenings like this make every tragedy that happened a fighting chance that the next one won't. And with our knowledge and understanding, we could approach it with acceptance and love. And, like you said, a smile might help, but we don't know. We could try our best. But there's no guilt. And we have to be comfortable. And with the knowledge that today, that we'll hear from Rav Siegelman, who has given me tremendous wisdom on this subject in dealing with some situations, we'll be more educated, we'll be more understanding, and perhaps we'll even be more effective. Chazak, chazak, v'nitchazek. I have to give this over to you.
Okay. All right. Welcome. Okay, so as he mentioned, my name is Siegelman. I did my Ph.D. in clinical psychology in the United States at the Catholic University of America. You can't hear? How about now? Okay. So I'll start again. I started my work in the United States, and I completed my doctoral degree in clinical psychology at the Catholic University of America, as it says here. And my specialty was clinical suicidology, is what it's called. And I'll get into what that is. I don't want to spend quite so much time going into data with you and research as much as I actually want to talk about some of the things that, unbeknownst to me, were mentioned here already, which I think is very telling of what actually helps people and hopefully leave you all with a better understanding and even validation for things that maybe you already know in terms of what can be essential for actually helping your loved ones, helping your family, helping your friends. So again, what I'd mentioned, I will talk a bit about statistics because I think it's relevant just in terms of being able to understand the magnitude of this issue and also the various pieces that play in and which ones are really important to pay attention to. I'll get into, as I mentioned, suicidology itself a little bit just to help people understand, like, wait, what is this? What's suicidology? What does this mean to study suicide? I think it's also really critical to be aware of myths. There are a number of key myths that come up with this issue, and I think that it's very important to dispel them, to be quite frank about it. And then ultimately, what's your role? Right? The people here in this room, some of you are professionals, I know that, but the bulk of people in the world are not trained specifically in being able to help somebody with this kind of issue. So what can you do? Right? When you don't have training, and you're not even qualified to get training. Okay, so I'm actually not going to talk about exactly what I normally do, which is the training for professionals. So the challenge of suicide, I do like to start with the United States because, well, quite frankly, that's where it started in terms of studying suicide, specifically as a scientific kind of focus. And it all started with a Jew that I'll mention, who's Edwin Schneidman, back in the late 60s, but I'll get to him in a moment. What we notice, right, is that there are similar issues here, obviously. We've had to face them. I've had to face them just quite early after we got off the boat, so to speak. We came here about a year and a half ago, and within a few months, it was something that came up, and people said, what do we do? We know what you do, so please talk to us. So in the United States, and this is really a result of COVID, of Corona, suicide was in the top 10 in terms of leading causes of death in the United States. This is the first time really in the last probably 50 years that we've seen an actual dip, right, in suicide in the United States. Normally it's around 50,000 people, so we see rates that have dropped a bit. What's disturbing, though, is that when we look at information about other life-threatening illnesses, they've all dropped significantly, right? Even become things that are not so concerning for us anymore. But this is the trajectory that we've seen with suicide, right? Since it became something that was really a key focus. And this is despite all the funding and all the research and all the efforts and all the people who care, right? Now, what we see as well that I think is really important, and it was brought up by Lazar, that I was really impressed with what he was mentioning about how it's really the people who are thinking about it that we actually need to be focused on, okay? Because if you remember the figure, about 45,000 people die per year in the United States. But look at how many people are thinking about it. There's 12.2 million people who are actually having serious thoughts. Right? They're in that place where they don't think that they have a reason to live, or actually suicide looks like the best option for them. Of these people, we see 3.2 million who actually are making plans, right, to actually take their life. Right? We'll get into the significance of that in a little bit later in terms of the relevance for how you can actually help somebody with this issue. Right? But about 2 million of those people don't actually make an attempt. Okay? But that leaves 1.2 million people who actually make a serious attempt of suicide, which required some form of medical intervention. And these are people who planned and attempted, and then we see a figure here for people who didn't have a plan. Right? It was just something that they did. Here's some information from the Ministry of Health's website in Israel, right, in terms of the number of deaths that happen. We always talk about in the United States about underreporting. It's an issue here as well. I've had people tell me, like, there's just no way that the rate is that low, that the number is that low. It's like, okay, fine. But this is, again, where I go into to look at, things that I think are important to pay attention to, right? We have seen a reduction in certain age groups, which I think is important. But perhaps more telling as well, we do see a rate reduction in terms of actual deaths. Right, if you notice the line, this gray line at the bottom, so that's the actual rate. Okay, the blue line is males, and we see females on the bottom. So there's a bit of a reduction. I think that's a good thing. But here's where it gets concerning again, like we see in the United States. People are still making the same number of attempts. It just hasn't changed. This is from the Ministry of Health as well, right? Here's the rate per 100,000 again, right? This is how we figure out, this is how we talk about rates. Because the number of people who actually die is, well, relatively small when we think about it. We talk about 6.5 out of 100,000, but you look at these numbers, 85 approximately who actually make a serious attempt out of 100,000. That's where we can get into this, this issue now, where unfortunately there wasn't any updated data on people who are actually thinking about suicide in Israel. It's something they poll people in the United States about on a yearly basis. This is data actually from 2001. That was the most recent data that I could find where they had actually polled a representative sample of the population as we talk about it. They took a random group of people and they polled them, and this was the rate that they came out with, 5.5%. Okay, which if we assume that it stayed the same, which would be hard to believe over the last 20 years, but let's just say it stayed the same, that's about 500,000 people, given the population, about 9 million. That's a lot of people, okay? We're actually walking around suffering. And then we move on to suicide attempts that I mentioned before. So just to highlight this and put it in perspective, so this is the challenge of suicidal ideation, right? Or thinking about suicide. So this is a population of people who are 80 times larger than the population who make suicide attempts. About 1,200 times larger than the people who actually die. So what's really the best way to actually respond to this huge population? Okay, it tends to be that hospitalization in the United States and also here is the go-to. And it's like somebody's suffering, we treat it like an illness, okay? We take them to the hospital, right? It's an emergency. Really what I advocate for is taking a different approach. Right? If we look at this not as an illness or a crisis, but rather as a person who's suffering, okay? We don't take people who are suffering and put them in the hospital. We sit down with people and we figure out a way that we can connect to them to see if there's some difference that we can make. No, I'll get into that. It's a good question, but there are cases where hospitalization is critical. Say it again?
There are times when the person is sent to the hospital, they're on some kind of medication to be able to do something, then you can work with them, or then you can't even work with them.
Correct. And so what I'll do is I'll summarize the issue here. If you have somebody, let's say, who is actively psychotic, for example, okay? They have command hallucinations. They have a voice in their head telling them to kill themselves, okay? That would be an example of somebody that you must take to the hospital, okay? You have somebody who behaviorally you can't manage the person, okay? They're another person who is engaged in extremely dangerous behaviors. Somebody has attempted suicide, right? These are examples where you would need to take them to the hospital. I'm definitely not advocating for no hospitalization, but as a go-to, as the first knee-jerk, that's a problem. Yeah.
How do you differentiate between self-harm and suicide?
That's a good question. Sorry, she asked, how do you differentiate between self-harm and an actual suicide attempt? Okay. The truth is, the way that I differentiate is by sitting with the person and talking to them about what happened, what their intention was. Because you're right, there are situations where we have something called non-suicidal self-injury, for example, right, which we find often attributed to an illness that some of you may have heard of, that's borderline personality disorder. There's a lot of self-harm involved. right? And not necessarily because the person wants to die, right? But it's something that is giving them some kind of relief, actually. But the way that I differentiate is when I sit with somebody, right, I'm talking to them about it. Because these things are very difficult, as you'll see, to actually look at, as the Rav was saying and as Chaim was saying, to just look at and say like, oh yeah, I can tell. We don't really have a system like that for suicide. So when we talk about suicidology, this is Edwin Schneidman, and as I'd mentioned before, really the father of contemporary suicidology. He's the person who really created the movement behind studying this and putting a lot of energy into it. He created the American Association of Suicidology. And this to me is really profound in terms of what's been mentioned here already, that suicide is caused by psych ache, right? Psychological pain. It's the hurt, anguish, soreness, aching. It's in the mind, it's in the psyche. And he really believed that suicide actually occurs when the psych ache is deemed by that person to be unbearable. And how did he even come to this? He actually took letters from thousands of people who had died by suicide and analyzed them to see like what's going on with these people, the people who actually died, what was actually happening. And the theme throughout all of them was terrible pain. So what is clinical suicidology? These are all the things that I deal with. All right, clinical theories to help us understand the best approach to take. The best way to offer support and treatment to a person. Clinical assessment to figure out the suicidal mind, right? The suicidal state of the person. Clinical treatment for that suicidal state. Professional training, that's largely what I've been involved in. Suicide-specific clinical risk management. This is really what I call process management, where I'm looking to get involved in systems and to help people understand the best way to streamline care, right, from start to finish, right, from when the person's in their home to if they have to go to the hospital, after the hospital, where do they go? Right, what's the approach? What do we do? And ethical and legal considerations. Right, these are also really important. We have to be sensitive to these issues. Now, moving on to myths. So asking someone about suicide or talking about it will lead or actually encourage suicide. Asking someone about suicide will actually cause them to think about it. Right. So asking about it actually reduces stigma, and it actually aids in prevention. And just to give respect to this kind of question, this kind of concern, there's been a lot of research on this also, just to validate the concern, but also this outcome. Right? Even working with extremely distressed people, even people who say, I don't want to talk about this, this is stressing me out. Right? Even those kinds of people, we find that it actually reduces their pain, reduces their stress. Yeah.
Does it make a difference if the person asking about it is sort of a healthy, mentally stable person, as opposed to, let's say, a group of friends who it's all on their mind and almost like triggering each other?
So you're asking about like a group of people who are kind of sharing in the experience?
Whether it's a myth or a fact, it depends who is sourcing the question. If it's something like, do you want to talk about it, it's something bothering you, as opposed to, I've been thinking about committing suicide, life doesn't work anymore, a group of teenagers kind of.
So listen, for sure, if people, the only case in which you could actually propose that you would put a person in greater risk is if you're actually encouraging them, right? So if I'm hearing you right, if you're in a group of people and you're feeling this way and they're feeling this way and it's like, hey, let's all go do this, yeah, of course. But that would be the exception, right? Depression causes people to become suicidal. Not everyone.
Sorry, just
Yeah.
go back to the previous one.
Yeah.
I don't fact that they do actually, the fact that they discuss it so openly, kind of like encourages it.
Uh-huh.
That's how I feel. I feel like because it becomes such an open discussion between themselves, that they're
Right.
all feeling the same way,
Right.
it kind of like legitimizes the option.
It could be.
That's how I feel.
It could be. It could be. So I think that's why these kinds of conversations are very important, to help people understand, like, how do we talk about this properly, right?
Isn't there a known copycat effect?
There is an issue like that. We call it like a copycat, but like cluster. There are issues like that too. Yeah, you're right. You're right. We see that going on. But I think that's what gets back to the point of talking about it, understanding it properly, so that we can encourage people to have resources, right? Have support that actually is supportive, right? As opposed to encouraging, right? To do something that's dangerous, right? Have a network of people who they can turn to, even call centers, right? I know that we have that here also. I've learned about things like that as I've been here, which is really helpful to know. As well in the United States, we've got that. Yeah.
When you were saying, as far as encouraging others to do it when somebody does it,
Yeah.
does it necessarily encourage them, or give them the courage to follow through something they were already thinking?
It's not planting it as a new idea, that's for sure.
That's
Yeah.
what it does.
Yeah.
Isn't there an aspect of a social contagion when it comes, just like there's in self-harm and other
Yeah, correct.
drug use? And
Correct. Yeah, that gets back into the same idea, though, right? In terms of, I mean, we can split the word apart and talk about the courage to be able to do it, or it's encouragement, ultimately. Okay, that would be the exception. But when we talk about depression, again, we don't see that people who are depressed are actually suicidal. There is a higher risk rate, okay? We can talk, the literature shows about 5 to 8%, right, are at risk for suicidal thinking as well when they're dealing with depression. You can see literature, too, though, that's talking about, except that about 98% of people who are suicidal don't have a diagnosed mental illness. There's a lot of argument about this as well. But ultimately, what it's getting at is that the best approach to take when we're dealing with somebody who's suicidal is to address the suicide. As I always say to people that I work with, if you can't keep the people alive, you can't work on anything else. That's why you have to focus on suicide first. Suicide cannot be prevented if a person is intent on ending their life. Most suicidal people don't want to be dead, as we mentioned before. There's tremendous pain. What they want is the pain to stop. Now, I've had people tell me that, no, I do want to be dead, Dr. Siegelman, but when we really talk it out, it turns out it's just because they have no hope. What they see is that life is pain, and that is all it is. So I just want that to end. It's like, okay, let's work this out. Let's see if we can find an alternative. Suicides often happen impulsively or out of the blue. Most suicidal people said something or dropped hints about this issue that they're dealing with. I have a colleague in the United States at Florida State University, Thomas Joyner, who he told me that he's worked with thousands of people who are suicidal. He said, I have heard about this impulsive person, but I've never met somebody like that. Maybe it's real. I've just never seen that, though. Ultimately, when you talk to somebody, you see that there is something in the background that you can actually identify when you're sitting with the person. Once someone is suicidal, they will always be suicidal. What we find that's actually really interesting is that active suicidal thinking is often fleeting. It's not something that's sitting there very long. This will be very relevant when we get to the piece on actually talking about the method of choice that a person who is suicidal may have chosen. But ultimately, the point that I will highlight is that this is why we find that when we take away whatever that means is, as we call it, the pills, the rope, the knife, whatever it is, the person is actually safe now. They actually won't do it, so to speak. They don't have the method anymore. So if the active suicidal thinking was something that was chronic, that was just always there, it may not play out that way. Because that fleeting moment, the person has the item that's there that can be used, right? But we remove that, right? So I'll sit with a patient, and they may still be suicidal, but it's like, well, we know the pills are gone now. Yeah, but how do you know I'll be okay? The pills are gone. Do you have something else? Well, no. Okay, so let's work on this. Let's work on this pain then. Right, the way I look at it is that when there's a method in the way, there's something in the way of our ability to connect. Okay, they have a relationship to that thing. Okay, because for them, up until now, it's been the source of pain-free, right? So now I'm trying to replace that. That's my intention when I sit with somebody. So people who threaten suicide are just looking for attention. People who discuss suicide are often seeking help, okay? They're not looking for attention. And what I always say to people is, you know what? Let's go with they're seeking attention. What a terrible thing that they feel a need to have to use that in order to get attention. That's very telling. You need to help the person. If that's the thing that they think they need in order to get your attention. Young children cannot be suicidal. About 30 to 35 children under the age of 12 in the US end their life every year. These numbers have increased. A lot of people argue, though, that it's due to the fact that people have actually started to become open to the idea that little kids can actually think about this. So up until recently, it was, oh yeah, that wasn't a suicide, that was something else. It was an accident. Hospitalization is the best and only option for treatment for suicidal people. I'd mentioned this already a bit, but hospital stays often don't offer effective suicide-focused treatment. And what we do end up seeing is that a lot of people who come out are at much greater risk in the end. And again, I'm not saying that there is no use for hospitalization, but you have to be very careful. Right? What's the context in which you're sending somebody to the hospital? Yeah, sorry. Yeah. That it would switch, yeah. There's an epidemiologist at the CDC in the United States who figured out that when a new idea is promoted, is presented, right, within the medical field, it takes 17 years for that to start to take hold. So you may have something that makes a lot of sense, you have a lot of data and research to back it up, okay, but then why aren't people taking it on? Well, because they have everything else they're familiar with. Say it again, sorry. Mm-hmm. The hospital is not dealing with the suicide specifically. The purpose of hospitalization is, right, stabilization. That's what we call it, right? Not treatment. Okay. Treatment is very specific, right? Suicide specific, to be precise. Okay. When we get into medications here, we just don't have data that supports the idea that medications are the best way to actually help somebody who's suicidal. Now, if we identify that, for example, oh, it's the depression, right, that's making me suicidal, the person actually says that, okay, so then, yeah, that would be an example of where maybe the medication will actually help, but you've got to figure out, like, is it really the depression? I'm getting a little off topic because we're getting very specific into the actual treatment that I do with people. So it won't be so relevant to everybody else, but it's an important question. Yeah. Right, right. There, yeah, we do see they call it a black box warning. Right. Correct. Right, right. You're right. You have to advocate. You do have to advocate. She said that oftentimes what you'll see is that a person who, let's say, is taking an antidepressant, right? They'll take the medication, but it actually makes them worse, right? Actually makes them suicidal, right? There's not, it's a separate issue, but you're right, there is issue connected to the medication and what it's actually doing for the person. But what we do know from the data is that there just really isn't anything supporting the idea that, for example, an antidepressant will treat their suicide. An antipsychotic will treat their suicide. A mood stabilizer, right? We have other interesting data that's going on. It's being developed now on alternative medications. They're also not showing us the kind of results that we would love to see. Yeah.
Without this fact, hospital stays often do not offer whatever.
Right.
Makes it worse. I don't know about anywhere else in this world, but the hospital that's around this area, I find that it's more like a prison.
So they are, right?
And they're so
Right, but why are they like a prison also? Right. Not to defend the hospital, but
they come out of the hospital wanting to commit suicide even more.
right.
Is a lot of the hospital's fault.
Correct. It's a great question. It's a great question. We're dealing with that in the United States as well, and you're right, it's something that has to be addressed. And I think that this is where it starts, it's education. Okay?
Saying I just want to clarify, hospitalization is not for dealing with the physical damage after an attempt. You're talking about hospitalization.
Oh, absolutely it would be, right?
Well,
We differentiate between medical hospitalization and psychiatric.
yes.
Yeah.
That's what I'm saying. Medical hospitalization is not is an attempt to save a person after they attempt something.
Correct.
That's something else. You're
Correct.
talking about trying to prevent suicide.
Right.
Or someone says, I'm about to commit, and then take them to a psychiatric emergency room.
Right, so ideally what you would do is connect them with a trained medical professional, a therapist who can actually help them address the suicide, not just lock them up, right, to this lady's point, in a prison essentially, right, to try to keep them safe, but in the end it ends up being like a prison for them.
Depends if it's a closed ward
Yeah.
or
Listen, we've polled people also in the United States about their experience of being hospitalized, and nobody has ever said like, oh yeah, it was amazingly therapeutic. Really helped me a lot. I felt so much better. It was the total opposite. It was terrible. It was punitive. I had no experience of therapy. Right? I never want to go back there. Right? I had one exception of a patient that I worked with who actually wanted to go to the hospital, and that's what he did. And you know what happened? He connected with a psychiatrist who was a friend of mine who had had proper training and actually worked with the guy. And he consulted with me. That never happens, okay? That was total hashgacha.
You would think someone would pick up on that, though.
Yeah.
Like, isn't it obvious if that's what they're supposed to be doing, that's what
Right.
they're supposed to be doing?
So we said 17 years, right? You're right.
But don't they like interview the patients when they're leaving and saying,
They don't, so we do. That's the difference. You're right.
I know somebody who had a very good experience in mining at Yeshua. I don't know if it's a closed locked ward, but they had a lot of things, activities and things, and it did help the person very
Beautiful.
much. Like arts and crafts and all different things, and
Right.
it was a very positive experience. It was
Good.
different than some of these other ones that people
That's good.
need help.
That's good. That's good.
And I just wanted to ask, you mentioned earlier about borderline personality. What is that?
Incredible emotional dysregulation. Okay, to be very brief. Right? The person is highly affected by things that you and I would just not be affected by. Wouldn't be a big deal. Right? It's just extremely upsetting for them.
And that
Very basic things.
medicine?
Yeah, typically medicine, but more importantly also very intensive clinical treatment. There's a clinical treatment model that's called dialectical behavioral therapy, but let me continue though. There's a lot more to go through. Suicide is always preventable. The problem here is I mentioned, I alluded to this at the beginning, but the idea being that if I look at somebody, right, or if I do some kind of blood pressure test, it's not going to tell me for sure what I'm dealing with, okay? So I can't stand up here and say like, yeah, I have the thing that'll help everybody and you'll be fine, right? That would be naive. People who truly want to die don't talk about their suicidal thoughts. It's not true. About 50% of people who die by suicide revealed their thoughts to someone beforehand. Right? And oftentimes it was actually a medical professional. They told.
Not 5 minutes before.
Correct. within the last 30 days, that's what we found. So here's some facts further about hospitalization. Right? In the United States, we see 1,500 inpatients, right, who die by suicide in the hospital.
When you said that they speak about suicide, they say, I want to die, or they say specifically what?
Yeah, they'll share. They're like, I don't want to live anymore. I'm thinking about suicide.
Teenagers always say that.
We'll get there. It's a good question. Let's, if I don't answer your question as I go through, we'll go to that. Hanging and jumping are the most common methods that we see in the hospitals. Somebody had mentioned, oftentimes we'll see a worse situation, right, with somebody who comes out of a hospital. Matthew Large talked about this as a nosocomial suicide, right, where the hospital is actually causing the problem. It's making it worse. It's causing it, as I put here, suicides that are caused by inpatient hospitalization.
Getting a sepsis, not getting hospital infections, it's the same idea.
Right. Iatrogenic, it also means that it's putting the person at risk. Okay. More hospitalizations, right? Also, it's not making things better. It's making things a lot worse. Here's what we see when somebody comes out of a hospital. Okay, and this is why people have said, hospitals they're not doing the thing that needs to be done for these people, right? So they come out, right? Literally, to be specific, it's about 300 times greater risk, right? When the person first comes out of the hospital. About 5% of all post-discharge suicides occur within one week. Most of those are on the first day, right, after the hospitalization. The 5% is after they get out of the hospital, right, so post-discharge. And 20% of all post-discharge suicides occur within 1 year of release. Here's the piece that I was going to mention about medications. Essentially, the idea is that things are just mixed, right, at best. Even we have the FDA is a huge governing body in the United States that typically people look at for validation of treatments. Right? It's like, oh, well, they said that treatment works, so that must be good. And look, a lot of this is born out of fear and just the feeling like we need to do something, okay? So they'll stamp approval on something even though there isn't data that actually supports that. And so that's what we see with clozapine as an antipsychotic, right? It works very well for schizophrenia, okay? And various other psychotic disorders, right? But it's not the treatment for suicide. It'd be wonderful if we had a pill for that, okay?
Is there any medications that are actually, like someone mentioned before, that there's indication they increase the chance of suicide?
So my approach is never to look for medication as a support unless there's a very clear indication that could be something that would help this person.
No, but
Okay.
I mean the other way. If you know that someone is at risk,
Yeah.
are there certain medications to avoid? To give you a name, Simplex, I've heard that by teenagers
I'm not a psychiatrist, so I wouldn't. It would be stepping over my boundary of competence to be able to answer that specifically. But what I do know is that when we're talking about treatment of suicide, medication is not the thing that does it. It doesn't make the person better, right?
my question was in first.
Yeah.
Do we know of any medication that make things worse?
That actually makes it worse. The data on that are not. It's not so clear. It's not so clear to be able to say that like a person takes an antidepressant and then they will become suicidal. Right, significant risk, that's not so clear. It's really not so clear. Right, to be able to separate those out also is difficult, but no, it's really not clear. And I do think it's an important detail because there are people who have depression, right, and they do need a medication to help them with that, right? So to go into this idea that like, but they might become suicidal, the suicide is an issue that's in the background already, right? If that medication is exacerbating that might be the case. Why would that be? But if you're dealing with depression, okay, ultimate example of depression, a person is completely inactive, right? They can't get up. They can't get out of bed. Now, if a person is also suicidal and they can't do anything, right, they can't take action. But now you give them a medication that makes them feel better, they get activated, suicidality is in the background, now you have a problem. It wasn't the depression. Okay. Sorry? Yeah.
You mentioned this slide or two ago that 50% of suicides, the person, 50% of people mentioned it beforehand.
Yeah.
I don't know if you can cover today, give us advice if we encounter a child, a colleague, a friend, what we should do if we
Yeah.
need to mention.
Yeah, that's what I want to get into. These are the newer medications that have been explored, also just not really showing us what we'd like to see. Ketamine is actually a general anesthetic for putting people to sleep for surgical procedures. What's really interesting is that they gave it to some people who were severely suicidal in the United States, and they got better, like totally better, for 72 hours. But because of this, I mean, it was really like day and night in terms of better. It was very shocking to people. But these people who had been chronically suicidal for most of their life came out, and then they're just like apologizing to their families for how they had been so ill, and offering help, and then 72 hours later they went right back in. And a second dose didn't help. It didn't do it. It didn't help them. Not yet. There are people in the United States who are really advocating for that because of how it permeates so many different diagnoses. It just shows up all over the place. And yet, there's no diagnosis that is the diagnosis, so to speak.
In depression, you can wax and you can wane.
Right.
Is suicidality similar where you can have exacerbations and a failed attempt and then get better and get worse? Do you find recidivism?
Yeah, absolutely. Yeah, absolutely. We find this with people who, for example, if a person has a multiple attempt history, okay, so they have a much greater risk.
What percentage of these patients have that?
It depends. Wow, of the people who've actually died?
No,
Who,
of attempts.
okay, or are multiple attempters? I don't know. That's a good question.
We have a number of how many people attempted and failed.
Correct.
How many of those attempted multiple times?
I'm not sure. Of the 1.2 million, for example, in the United States, or the 6,200 here, I don't know. That's a good question, though. That's a good question. Yeah, let me move on. Sorry. I've just got a lot of important things that I feel like are very relevant to you guys that I don't want to not get to. Okay, so this I also think is really important to be able to understand, right? A lot of the talk that goes on that I hear even here is around what we call risk factors. It's like, let's figure out what the issues are, right, that are leading this person to feel suicidal or leading people to feel suicidal, so then we'll know what to look for when we're looking at people or when we're talking to them. So here's a brief synopsis of all the risk factors. Okay, and I didn't list them all because it would overwhelm you guys. There's literally hundreds of risk factors. Okay, so this, to be very concise, this has not been helpful. It's been very interesting, right, in terms of the research population, but in terms of actually helping people, it doesn't cue us in as to like what to look for. This means what I just said, right? It's not helping us understand like who is at the greatest risk, right? Given the risk factors that I just showed you. Warning signs I think about in terms of like a heart attack. Okay, so risk factors, obesity, smoking, right? Lack of exercise, poor diet, right? Those are risk factors, right, for heart disease. A warning sign, right? Pain in the arm, right? Shortness of breath, fainting, right? So what people had hoped was that, hey, if we can identify warning signs of suicide, so maybe that'll also help us distinguish who it is that is going to do this. We can catch them. Again, we see the same kind of pattern where it's not really working out. Anger is something that is unique, right? Where it did show some indication that maybe that's something that we could key in on, but again, it's not reliable, right? It doesn't work out that way all the time. So what's your role? What's our role, right? As friends or family?
Basically, what you said before, self-harm is not necessarily an indicator.
Correct. You have to talk to the person. So that's what we'll get into here. All right. The way that I really conceptualize us, right, as community members, friends, and family members, okay, it is first responders. And I really say that because we have the best sense of who in our family or who among our friends is in distress. We know them the best. We're the closest with them. We're around them the most. We have the best opportunity to be able to actually interact with them. So I would say, like, ask the question then. I'll get into how. How do I do that? The tendency, though, when we see something that is scary, right, that is concerning, oftentimes the tendency is to just ignore it. Right? I don't want to deal with that. It's uncomfortable. The next tendency that people have is to connect, but they're not going to really ask any questions. It's just like, oh, how's your day? How's it going? How you doing?
Skirt the edges.
Yeah, exactly. Right? Walk around the proverbial pink elephant in the room. Right? I don't want to talk about it. The next group, right, it's connect, but you try to ask in an indirect fashion, okay? Because you're nervous again. This actually comes from a work that I was privy to from security professionals when they were dealing with a suspicious person. Right? It was like, how do you approach the person? Right? This is what they found when you're dealing with something that's very anxiety-provoking. Okay. So the fourth option of connecting and empathizing and actually asking directly, that's not the normal approach that we take. That's scary. But what I hope that I'll accomplish by talking this evening is that you'll come out feeling like, oh, okay, I can do that. Okay, that makes sense. This is what I mean by direct questions. Okay, this is very formal. Okay, this is for professionals, but something that lay people could use also. This is actually a screener, a questionnaire that I helped the National Institutes of Health in the United States develop for hospitals. Okay, it's non-proprietary, so if anybody's a healthcare professional here, you're welcome to take it and use it. And we can be in touch and I can send it to you. I've been working on translating it to Hebrew with a team here so that we can bring it to Israel officially. But let's deal with some key issues. Okay, what if you're just afraid? You're afraid to ask questions. Okay? I'm a big advocate of self-care. Okay, you've got to address this in yourself. Okay? If this is something that you're dealing with, right, you're afraid, so you have to honor that. I like the idea of writing. I know some people, I don't like writing. I've tried that before. Writing is really something that helps you to understand what's going on. Okay, I'm going to get into like how do you do that though, right? How do I write and understand? Yeah.
To write to be able to ask the questions, or to write if you're having a thought?
Writing about the fear that you're experiencing, right? Like of asking the question, like wait, why am I afraid? Let's write about it. Let's explore this. Here's some like really specific questions to be asking yourself. Say it again. Sure. Yeah. So some of the questions. I've got 3 questions here. Okay. If you're afraid, right, so how can you, right, the person I care about, how can you want to die? Right, let me explore that. Let me write it out. Number 2, why isn't my love enough to make you want to live? Number 3, why can't you be happy or at least at peace with what you have in life? Say it again. Yeah, so the other side over here is understand. The purpose of writing, right, is really the understand. Yeah, these are all just like common fears that show up, right?
You said the question is to ask yourself or
to ask yourself.
Not the other
These are dealing with you, right? I'm afraid, right? If this is something that you're experiencing again, right? If you are afraid, that's fine, right? Let's deal with that.
This is, I'm sorry.
Yeah.
Okay. When you're faced with someone who you think is suicidal,
Correct.
this is what you should have them bring out.
No, this is what you're asking yourself first. If you're nervous about dealing with a conversation with them, right? You're like, Asher, I can't ask the person that question. It scares me to just bring that up to the person.
Questions on the right are what you're scared to ask.
Yeah. So you ask yourself, right? Ask yourself, like, what's going on, right? as a source of exploration to understand and work it out, right? Because the objective here is for you to be able to go in and actually talk to the person. But if you have, let's say you feel guilty or you feel afraid, okay? It doesn't go away magically. You have to work that out. It's something that's there. So let's explore, like, wait, why are you feeling guilty? For yourself. Like, why am I feeling guilty? Why am I feeling afraid? I would love to, and you're right, it does this requires some training, but I don't have time, unfortunately.
Are these the same questions that they're asking somebody that is suicidal?
No, this is just for you right now. Self-care. Take care of yourself. Let's start there. Get yourself stabilized so that you can then work with somebody who's at risk. So I'll get to that. Okay. But we have to deal with like what shows up for people, okay? And these are issues that I've run into when I'm just trying to help somebody support somebody that they care about, okay? So this is another, as shocking as this might be, this is something that I see showing up a lot more with men, okay? What if you're just judgmental or critical? Suicide is a choice, right? Like let's explore that. That's actually your criticism that you have of this person, okay? Just choose something else. Why do you got to choose that? Suicidal is never rational. To the person, it might be. But explore it. Suicide is selfish. That's a big one. Not to the person who's exploring that. You have to work on this for yourself. Suicide is a sin. People who die by suicide are weak or cowardly. These are criticisms that show up for people. Okay? So rather than sit there and feel guilty that you have it, right, work it out. The worst thing is to come into a situation to talk to somebody and that's there, right? Like, yeah, I really want to listen to you, you know, and in the background you're thinking like, gosh, this guy's so selfish, right? Or this lady is so selfish, whatever it is. Right? They can feel that. They can feel it's not genuine. You're not coming from a genuinely caring place. Correct.
Before the conversation.
Yep.
But they're not part of
Yeah, we're not talking to the person yet. You need to process these things for yourself first, if they are issues, right? As you mentioned, like these might not be, which is fine. So how?
Just one,
Yeah.
just as an example, suicide is a sin. So, okay, but I need to put that aside for this conversation, or
work it out for yourself. Work it out for yourself. Right, there is something that I've become aware of as a specialist in this area. I'll try to be very brief. The Gemara talks about a person who dies by suicide as a what? A me'abed atzmo ladas, right? If you look in the Shulchan Aruch, it distinguishes that from a me'abed atzmo shelo ladas. The me'abed atzmo ladas is extremely unusual. That's the person who is vindictive, who uses it as a method for hurting other people. Okay, it's what I call, and other psychologists call this the dark side of psychology. Right? I can't go into it exactly, but it's like the sadism, the narcissism, the psychopaths, Machiavellians.
way to manipulate other people.
Right. And we do see that. It's just very unusual. But that's why I say you got to explore it. You got to think about these things. Emotions that can arise. Okay, still, we're dealing with ourselves right now. Okay, we haven't gotten to the person yet. We're just considering, like, wait, are these emotions that show up for you? You have to work through them. Work on, like, what am I feeling sadness? Like, why am I sad? How is that going to help the person? How is that helping me? There is a big issue, obviously, of not wanting to publicize something like this, right? Not wanting to even reveal it to anyone, okay? But the consequence also needs to be considered. Okay, so, okay, let's say I'm not going to share with anybody, so then you are reducing your ability to connect to people, to get support. There also is this fear that it's going to get revealed that comes in.
Talking about the person, not the suicide.
You, again, still you, right? ultimately connecting with another person, right, is going to give you the ability to actually talk about these issues. Okay, there are two people in this situation, right? We haven't gotten to the second person yet. There's you and there's the person who's suicidal. So, okay, we can keep it totally private, but then you're not going to connect to the person who's suicidal, that's for sure. Right? I don't want to talk about it. All right, well, you need to talk about it. Okay, so that requires connection first. You gotta connect to this person. Okay, but now the two of you, if you can connect, right, and you can, okay, to somebody you care about, you can then discuss something like this, like privacy. What are we going to do? You can discuss support too. Who's in our support circle? Let's think about it. You don't have to reveal it to everybody, right? There is stigma, right, with these issues. So we reach out to people we can trust. Who can you trust? What do you do if you don't have a support team?
Is that
Yeah.
for the person who is helping the other person, or just the person who needs the support system?
For both. It would be for both.
Have this conversation, then that's when you discuss support.
As we're starting, right? We're starting to now approach actually talking to a person, okay? Like I'm going to work on the issues that I'm dealing with for myself first, right? To make sure, like, wait, can I come into this situation and really talk things out with this person, okay? And now when I start to talk to this person, right, let's explore these ideas. Like, wait, who do we have in our circle? Who can we reach out to? Right, but what happens if you come onto the idea that, like, wait, I don't really have anybody to get support from? This is where I think it's really valuable to take some theory and implement it. We all have feelings and we have beliefs. But the reality is that we want to tune into these not equaling facts. Okay, we have feelings and we have thoughts. So we need to work those out. We want to try to create a realistic perspective, right? So if we're ashamed, okay? We're ashamed about what's going on, okay? So that's a powerful feeling. It's a powerful emotion to deal with. Okay, but to work through it, right, it gives you the ability to then see things from a more realistic perspective. This comes from cognitive behavior therapy. Oftentimes people will look at that theory and say, like, oh, it's trying to get me to have a positive attitude about life. And that's not true. It's trying to get you to have a realistic perspective. Sorry? Right. But also giving credence to the emotion, right? Giving credence to the beliefs that you do hold. Okay? Some people like this kind of distinction, right? They like to be able to distinguish things. Right? These are called cognitive distortions within cognitive behavior therapy. Right? All or nothing thinking is like, it's very extreme. It's all bad. Everything's terrible. Right? Hindsight bias. If only I had known. Okay? These are things that leave people in a state of distress. To simplify things, so what do you tell yourself? So some questions, okay? Just 3 questions. What do you tell yourself about what you're experiencing? Number 2, is what you're telling yourself a belief or a fact? Like really work on just taking it outside of yourself. Right? These feelings can be very deep and they can hurt. So by taking them outside of yourself, you can, as I mentioned before, writing about them, it helps you to really process these things. Number 3, how does it affect your mood to believe that about yourself or about the other person? To make it even more simple, you have a belief, you have a feeling. Just put evidence for and evidence against.
We're still talking about the person who's yourself.
Yeah, yourself. Still dealing with yourself, right? These can be tasks also that you help a friend with, right? If you're sitting with somebody who's struggling, right? You can talk to them, and as you're connecting, you can say, like, hey, I've got this thing that's helped me. Maybe we can do this together. Let's be realistic, though, right? That's what we're doing. So what if your belief or feeling is actually fact? Maybe you did make a mistake. So how can you correct that? Maybe the person actually is getting worse. So is there anything you can do to help the person? Maybe you are exhausted. So how can you create a schedule or a situation that will allow you to actually rest? What if there's really no apparent solution?
Solution to what?
To the situation that you're dealing with, right? That you can't correct the mistake, let's say. There was a mistake that you did make. You messed up. And it's too late. There's nothing you can do to actually fix it. Right? The person got worse, and there's nothing you can do. Okay? You're exhausted, but you can't rest. There's no solution. Again, it's all about just being realistic. Right? Wait, what are my limitations? Okay, do I actually have the ability to deal with this issue? You can't sit and watch somebody 24/7. Okay? If there's somebody you're concerned about, and if you want to claim like, yeah, I can do that, you can't read their mind. Okay, so you can't do that forever. Right? There is going to come time where you're going to need to go to the bathroom, right? Get something to eat. Right? That's a real limitation. Guilt. This goes back to the model of like, okay, evidence for, evidence against. And it's something that you're experiencing. It's like, okay, you need to process that. That is there. By saying like, yeah, I'm not going to deal with that though. It'll go away. It won't go away. It's there. It's there for you to deal with. You have to work it out. Self-compassion. I think this one's really big. Yeah. Distinguishing first and foremost, like, well, maybe this is a moment of suffering. Right? There is real suffering here. Suffering's a part of life, perhaps. May I forgive myself? May I have compassion for myself? Really using this as an exercise to talk to yourself in the mirror. Right? Like work out, like, wait, how harsh are you being in actuality with yourself? So now when we get into actually asking the question to a person that we're trying to connect with, so a big assumption, right, that has people actually ignore the question is that they'll tell me if it's something that they're actually thinking about. So the question asked is like, well, would you? If that was something that you were thinking about, would you tell your friend or your father or your mother or your brother, your sister, your Rav? Would you just offer that information? It's pretty rare. You might, but it's not so common. We look at data by adolescents who have made suicide attempts. A third of them never told anybody. It's a private matter. Yeah, they attempted and they never revealed it to anybody. Half of the adolescents who are struggling with suicidal ideation, who are actually thinking about it, never told their parents. It's really important. You got to ask the question. Why would somebody hide their suicidality, though? Why would they do that? A lot of reasons, a lot of emotions. What's the most prominent one, though, that we see, most prevalent? Just put me in the hospital. Why would I share that with you? That is the common reaction that we have to this. Got to send him to the hospital. Not if we look at it as a state of suffering, then. It could be that that is something we need to do, but let's slow down. Embarrassment's the next one. Shame and embarrassment. Those are the next most common ones. And how about you? What frightens you about asking? Right? So these are common issues that people have brought up. Too intrusive, the person's going to get angry at me.
Angry for asking about.
Yeah, yeah. It's like, I want to ask you, but I don't want to make you mad at me. Right? It's too personal. It'll make the person feel worse. This is why the knowledge about myths is really important. The person won't be honest. People are extremely honest when it comes to this conversation. It's very interesting. When you're real direct, the responses I've gotten from people is like, wow, I've never met anybody who's so willing to just be honest and talk about it. I see people dancing around, so I won't even tell them. I won't even let them know, because I can tell they don't have the courage to deal with it. So what if the person says yes? All right.
Clarify,
Yeah.
Like, say the question out is what they say yes to.
Yes, I'm suicidal.
And you said, are you suicidal?
Yeah, so you say, like, hey, is this something you're actually thinking about? Right, to be very brief, it's like, hey, Noah, I can tell you're dealing with something. You're in a lot of distress. You've told me all these things that you're struggling with. I know that people in this situation can sometimes have this kind of thought. They can actually think about suicide, think about killing themselves. Is that something that you ever think about? And you say, yeah. Empathy and compassion.
People also honest about when they're not.
Yeah, they actually are. Actually, it's a good question. But that is something we find as well. When they're not and they say no, it means no. When you're that direct.
They have a plan after they say they're suicidal.
Yeah, we'll get to that, yeah.
Could you define what suicidal ideation? Could you give us some brief? I've heard that used a lot. What is that?
It's so two things. Thought of either purposefully ending my life, right, or a thought that I would really like to be dead. Right? So that's where people get into this distinction of active versus passive. Right? Oh,
I mean, I'd prefer to be run over by a bus.
so that would be more passive, right? Judgment and persuasion? No, that's not what we do. The idea of empathy, right? This is what this is the best definition that I've gotten of empathy, right? It's really listening in order to understand. Okay? It's not coming in to say like, well, at least you have a good job.
Isn't it sharing the feeling? It's not sharing the same feelings that the person is?
So to be concrete about it, though, it's like, man, that sounds really hard. Thank you so much for sharing that with me. I don't know what to say, but I'm glad you told me. Let me just sit here with you. As long as it takes.
Sometimes you say to someone, I can understand how you feel. You go, no, you don't. No, you can't.
Right, so that's why we don't say, we never say to somebody, I totally get it. Right? It's like, no, you don't. You can use understanding. It's like, hey, I would really like to understand this. Can you help me grasp this? What's happening here? What people usually do, change the subject. Advice is a big one. I've got some good advice for you. Here's some tips. Start lecturing. Listen, life is so valuable, and you have to go on and think about your children. Trying to persuade or convince people. Reassure them it'll be okay. Don't worry. You'll be fine. Hey, why would you do this? Because you don't like feeling helpless. That's why you would do this. You don't like feeling worried. You don't like feeling stressed out. So now, when you give fantastic tips, you'll walk away being like, wow, that was really smart. I should write a book about how to give people tips.
Sorry, what's the difference between reassurance and empathy? Of like, I'm here with you, we'll get through this together versus empathy.
So I didn't say, I'm here with you, we'll get through this together. It was, thank you so much for telling me. I don't know what to say, but I'm here. The way I envision it is that you're quite literally putting yourself in a position where you're entering the darkness with them. So the question to me is, can you sit in the dark? Can you actually do that? So that's why I really do push and emphasize the self-care. See, that really does require preparation, because the darkness is scary. Can you really listen? You listen to the complexity of the pain, right, this person is dealing with? It's a loved one. So I'd like to say yes, you can. Connection is the key here, okay? We think that it's something that we say or it's something that we do. Really, it's none of that. It's just being able to be with a person. Being able to be connected. To sit in the dark with them. And just be there. But we have this need, again, like I got to do something. It's like, it's strange, right? Because it leaves you, it's like that is what leaves you feeling like you've been productive, as opposed to just sitting with the person or going for a walk with them, whatever the connection is. So this is where we get to a suicide plan, but it's almost like you have to earn this, okay? So once you've established connection, you've enabled yourself to essentially instill some hope in them. Like, wow, I actually have somebody who's willing to listen to me and be straight with me. Then you can actually ask a specific question. Are you thinking about killing yourself? Yes. Do you have a plan? How would you do that? Where? When are you planning to do this? And trust me, I've had people say, like, I'm not telling you. And remember the most common reason people will hide it? You're going to put me in the hospital. So why is that important to know? Hey, do you think I'm going to put you in the hospital? Is that something that somebody's ever said to you? Yeah. That's not what I'd like to do. I don't want to have to do that. But we need to be able to work together. I need to be able to talk to you about this.
It is, by the way, what they tell each other. Because I know someone who went to a hospital and they tied him to a bed and they gave him shock therapy.
Yeah.
And don't say anything because you'll get into trouble.
Right.
That's what they tell each other.
Right. Right. This gets into safety planning now, okay? What do I mean by that? Stabilization. This is where I mentioned reduce means, right? Essentially, okay, the person says they have a plan. Okay, I just ask, like, how would you do it? I have these, here's my pills right here, right? My pills. Yeah.
How long is the process? I feel like
Mm-hmm.
you're approaching whoever,
Mm-hmm.
right? First thing to do is self-care. How long
Right.
is that process? Then how long does it take to connect? And then how long does it take to get to that point where, good, actually answer the question.
Mm-hmm.
This is like, I'm not the therapy just for any one of us sitting here.
That's why I also think, like, I was asked earlier, like, can we do a mock run of this? Can we see how this is done? And I agree. Like, this is something that it might require training. That might be something that's actually the reality.
Awareness that this is something that
Mm-hmm.
exists in the universe that for all of us sitting here really has only been possible.
Correct. And it depends on the issues, too, that you're dealing with, okay? Because it's like somebody who this all makes a lot of sense and it's obvious and, like, they have the kind of relationship that would enable them to be really honest and, talk to the person. What I say to people is like, hey, your kid's not listening to you. Just tell them, you know what, I'm here for you. Whenever you'd like to talk, just let me know. I'm available. I see you doing these things that they're kind of concerning me. I'd love to be able to help you. I do care. No, you don't. It's like, okay. Whenever you're ready to talk, I'm here.
Can I comment about
Yeah.
hospitalization?
Yeah, sure.
People thrown in hospitals under the bus, and they're not going to admit every single person
Correct.
who thinks about suicide.
That's right.
They're going to admit people who are at a risk right now to hurt themselves or others or are psychotic.
Correct.
Need to be tied to a bed and need to have shock therapy,
Yeah.
not to someone who's thinking about it.
Correct.
So I think we have a very negative, and I'm not pro-hospitalization, but hospitalization should be reserved for those who need it,
Correct.
and those who need it really need it.
Absolutely. That's very true. I know the tendency is to start to think about how, like, hospitals are all bad, right? And there is no function, right? That's not, again, that's what I was, right, that's what I answered at the beginning, right? There are very clear purposes for this, okay? But when we're specifically dealing with a person, right, who is sharing that they're suffering, right, that's not what we try to do. We don't try to send them to the hospital, okay? But again, the 4 topics, right? They've made an attempt, right? They're unmanageable, right? You can't actually, they're dangerous, okay?
But shock therapy has never been proven to work for suicidality. Like we talked about, it's for severe, major depressive disorder.
Correct, correct,
Refractory medical therapy.
correct.
So like, let's.
Yeah, I know, ECT also has a bad rap, right? Yeah, electroconvulsive therapy is the shock therapy, right? It's got a very bad rap. It's surprisingly, sorry? Maybe, but it was, it's very anticlimactic when you watch it. It's like, oh, that's it? Like, they do it at Emory University, where I went to university for college for my bachelor's degree. The medical facility, that's what they do that. They offer that to people who are suffering from severe treatment-resistant major depressive disorder. Okay, and it does show to, it does work for some people.
But I think the tools that you're giving us tonight are able to, and also, I think we also need to recognize that every single case is individual.
Yep.
It has to be handled, and every single one of them is very, very complex.
Yep.
Okay, so there's no right answer for anything. It has
That's
to be
right.
individualized and say this is going to work for this, this, and this. And I think to the point of like what the kids talk about amongst themselves is very, very detrimental.
Mm-hmm.
Because obviously they're unifying the diagnosis and they're putting it all together.
Right.
And so I think what you talked about, and was brought up already, is about the communication, about the connection, and about the non-judgmental empathy. I think that's the bottom line, and that's the foundation.
Yeah, correct.
More than that, you're not making us to be, clinicians,
Mhm.
right? That would be wrong.
Correct.
We're no gay of aides.
Mhm.
We can't, we are always positive, saying, oh, our kid is not going to do that, because I know my kid, because he's 18 last years, and it's always going to get better. Just around the corner, it's going to get better, it's going to get better. So we're no gay of aides, we can't make that judgment. We need to have a professional.
Mhm.
But those tools that you're giving us, I think, are the first step.
Yeah, 100%. Right, and the reality is, like, I know full well that as a psychologist, I'm not on the top of the list in terms of people's interest of having a conversation. I'm about number 7. They've done research on this too. But, like, the people that will be most apt to talk to you first, right, are your friends, right? Your friends, your family, right? Maybe just like a general medical professional. Okay, like, I'm really struggling here. You have the medication I can take, right? And I'm very low down. Okay, that's fine. Right, but you're right. You're right. And I think that gets back to a question that was asked over here from the ladies that was just like, wait, how do we do this though? Right, it's like, it's very individualized, right? It is complicated, right?
Is there a workshop for this?
It's called, get a Ph.D. in psychology.
No. I'm gonna hopefully address that as well. This is a start. It's kind of like a pilot run. Let's see how this goes. Once we can remove whatever the method is of a choice, this is where we can then get into a conversation about, hey, let's work this out. Let's see what else we can do. Right? When you're dealing with real distress, you're really having a situation that's a crisis. Right? Let me help you out. We can do this together even if that's helpful for you. Right? Really explore other coping methods. Right? Remember, the suicide was the coping strategy for them. Right? If you take away the ability to actually do that, in other words, you take away the pills, right? So you can't just leave them. It's like, oh, now you're fine.
Not everything can be taken away.
That's also true.
I mean,
Right?
you can't knock down all the tall buildings.
Correct.
Just
You can lock doors though that lead up to the roofs. Okay. So
the child that you only spoke to over the phone.
correct. Right. That's why again these are complicated cases that need to be worked out, individually. Right, to really think about them. But these are things also that you can explore, okay? Just to see wait, are there creative ways to work on this? Right, sometimes what I'll say is, somebody will say yeah, this person's method that was driving, they're thinking about killing themselves in a car accident. And so what I work out with them is putting up and they have to drive, they go to work, pick up their kids or whatever it is. It's like put a picture, a picture of their kids as something that alleviates some of that distress. It's like, oh, put that on your steering wheel, right? Oh, yeah, there's this song that calms me down. Put that on the radio, right? It really does require thinking out of the box, right? What I'm hoping that I can do, though, is leave you guys with information that's like, okay, I think I can put some pieces together here. I don't have to run off and get a Ph.D. in order to do this, right? That's not effective, right?
Quick question.
Yeah.
One is, how much does psychotherapy help people not be suicidal from their lives? And the other one is it something that anyone that contemplates suicide has some kind of mental health disorder?
No, the opposite. It's not most people who are contemplating suicide do not have a diagnosable mental disorder.
Not even anxiety,
Anxiety might be there, but again, it's something that we would have to ask, have to find out by talking to them.
what about therapy? How much does that help?
So it depends on the therapy. Okay. So if it's therapy that actually focuses on addressing the suicidal issue, so then it helps tremendously, right? But if a person comes into a therapist and the therapist says, you're suicidal because you're depressed, so I've got a great technique for working on depression. It's like, me as the suicidal person, I'm like, it'd be kind of nice for me to tell you why I feel suicidal. I had a guy in the United States who had schizophrenia. He was in his 80s. He had attempted suicide twice. And when we came in and met with him, the first thing we started working on, right, was identifying, like, well, what's the cause of your suicidality? Like, what's going on? And he said, nobody's ever asked me that. They always said, oh, it's your schizophrenia. And he said, I know how to manage that. Like, I've dealt with that my whole life. And he did get better, but, right, again, suicide was the focus. That was the key that we were trying to clarify with him.
You're saying that there are a lot of people who attempted suicide or that they weren't diagnosed, or that there's no, that even if meaning looking backwards, we just know that they weren't diagnosed, and maybe there was something there, or there is no diagnosis?
Let's be clear, suicidality is not a diagnosis.
I know,
right, not yet.
no,
So,
they didn't have any other mental health.
yeah, there are a lot of people like that.
They have no mental health.
They don't have what we would put as a DSM, or a diagnostic and statistical manual diagnosis, right? They don't. They're suicidal though. Okay, that's why people have been advocating for creating this as its own unique diagnosis, right? And they're pushing hard. So I'm hoping that the next DSM it'll be something that's brought up for consideration.
The drug companies make a drug for it.
Yeah, that's true too. It's true. Maybe that's why they're pushing ketamine really hard. Maybe. Yeah.
If we're holding by, taking away the pills, loaded gun,
Yeah.
it almost feels like, oh, we're relaxed. Let's take away the gun. Let's relax. Like, it almost feels like tie him up, like he's gonna shoot himself.
Mm-hmm.
It seems like a contradiction. Like, what kind of state are we in right now? We're taking away a loaded gun.
So once you take away the loaded gun, so now you've taken away their access to being able to actually take action.
But if they're holding there, they might just go look for something else.
And it's fascinating because what we find is that they don't do that. And that connects back to a point that I made earlier, which was that this state is actually very brief. Right? The actual moment where the person is at greatest risk is very brief. But if they don't have access to the method that they had, they won't just go create a new method. Yeah. Yes. Yeah. Right. Right, but what you're providing now is the hope, right? That fills the void, if you will. Correct. That's also true, yeah. It does, you're right. Yeah, you can't come in and just tackle a person and take away whatever it was, right? And then now they're good, right? No. That's why the whole previous section was about connection, right?
What,
Yeah, go.
what you said, to add to what the lady just said just now, is that sometimes it's not just a matter of the method, it's also the place. And I'm talking from experience. Sometimes there was with the person that I was involved with, and they said, I didn't want to go there because I was afraid that that's going to just happen again. So if I'm not there, I'm safe. Meaning
Right.
I wanted to go somewhere else because I'm afraid that there I'm not safe. So
Right.
by putting me somewhere else, I'll be safe. So
Okay.
meaning the only place they could think about it was doing it when
Yeah.
in that place that keeps triggering all the bad feelings and the
Very
bad
Very good.
situation.
Very good. Yeah, what were you saying?
And just to add to what's been said is when you address a person who is going through something difficult and has suicide ideations and you ask them about the plan, it's actually, in my experience, very brief. They touch on it and they say, yeah, I did, but not anymore. Like it's like a send of apex and then it comes down. It's not as if you're going to re-apex them and get
Correct.
to that point.
That's correct.
And also the fact that you're asking, when I've done this clinically, they actually, you can see that their whole body language changes
Mhm.
and they become more relaxed. And I know
Right.
they're asking that.
Right.
And it changes their entire attitude.
Yeah.
And so it's a critical tool that you may think, what happened, it's going to cause. And
Yeah, no, it really reduces the emotional center of the brain, right? So it calms that, right? Because that's highly activated when a person is in this state of distress, in this state of suffering. So it calms that down, and by you connecting with the person, you talking to the person, you're activating the frontal lobe.
And they're not
Right.
alone. They're not alone.
Right.
They always come to you in your safe place.
Correct. Yeah.
Sorry, I was going to ask this again, but
Yeah.
we kind of loop back around to the topic of that's suicidal ideation and active suicide or situation specific. So
Right.
I'm wondering how's a person who is unable to escape their situation, like in like a double bind situation, assisted, and on top of that, what if that person is a child?
Mhm. This is why I think that I'm a I think what he's asking is that if you're dealing with a child, right, who is essentially trapped in a situation that's dangerous for them, right, and there is no way out, right, so what do you do then in a situation like that? There isn't a solution, so to speak. Anytime I work with a kid, okay, so the parents have to be involved also. Okay. The parents, unfortunately, are not always supportive. They're not always helpful. That's why I bring them in. Okay. It's wonderful when they are. Right? It's difficult when they're not. But that does require. I think that's one of those scenarios that really does require professional intervention. Okay. Right. It needs to be dealt with in a very careful way. But if you're a friend, right, and you have that kind of rapport, that kind of relationship with these people, and you can actually make some headway, like at the very least, like helping them get to somebody who can help them, right? There's still a role, right, essentially that you can play to explore. Right. Let me just move on a little bit. I think we're almost done, but I can take more questions. All right. I think we've already highlighted this. Okay, connecting to people is decreasing isolation. Okay, not just to the phone, but just in general, connecting. So what do we cover? All right, connection. Right, that's the essential first stop. Right, you got to work through that. And by virtue of the fact that you establish connection with a person, you are inherently instilling hope. So while you may feel this need to do something, I need to fix them, I need to encourage them or reassure them, right? Just know that by you connecting to the person who is suffering, you're giving them hope.
You are.
Yeah. It doesn't need to be talked out explicitly, right? But you can watch it and experience it with a person. And then you can get into this place where you actually look to create coping skills.
Sometimes I thought you're not saying to tell the person there is hope, because
Correct.
sometimes they'll reject that, right?
Exactly.
There is no hope. If there is no solution, nobody can help.
Correct. Right. Yeah, it's just, it really is that nonverbal, right, relationship.
When a
Yeah.
person feels that they're in a no-hope situation,
Yeah.
that is the problem. When you connect with someone, you automatically give them hope, because now at least they feel comfortable enough to be able to share their problems.
Right.
Until then, they have had no person to share their problems with. When they have somebody that can just share their problems with without judgment, without being told what to do and how to do it, that's giving them hope of it.
Yeah. What not to do, what not to say. Don't deny or dismiss people. Okay? Don't deny what they're saying. Don't start panicking. Okay? That's never helpful. But again, this gets back to the self-care piece, right? You got to be able to process these things so that it's something that you can be, stable yourself, okay, before you go in. Don't focus on your feelings. This is really stressing me out. Really, you can. Somebody will actually start to feel bad themselves. Like, I'm sorry. Like, I'm okay. Don't worry about it. I'm actually fine. And that's not the reaction we want from a person who's suffering. Starting to take care of you. Start to persuade. I mentioned this. Trying to fix them. Lecturing or judging. I think we brought this up. Like, I totally understand. Don't say that. It's not helpful. Guilt the person, give ultimatums, dare the person. Yeah, right. What do you do or say? This is all connection, right? All this language here is connection. Show appreciation. Thank you so much for telling me. Tell me more. Learn more. Express empathy and compassion. Address being a burden, if that's how they feel, right? Or not being a burden. Yeah. Yeah. I think therapy is always a great option, okay? What I'm encouraged by is seeing the people, even in this room, who actually have training that I'm like, yes, okay, now they can handle this. I've got a few colleagues in the country also that I've found that I'm hoping to have more people that can really help out with this issue. I found that people care a lot here, though. So even when I connect people who I'm concerned about to another therapist, I'll consult with the therapist and help them to approach this properly. But I think therapy can be really great, right, when it's done properly. Yeah. I think it's best to use it when it's something that you see an indication for, right? It's like, listen, I think there's some relevance if we're talking about it in terms of like, okay, there's a thing called drugs in the world, okay? So would you talk to your kids about that? Yeah, at an age-appropriate time, like that would make sense, right? Yeah, so I think when it's a situation that you're dealing with where you see clear distress, okay, and you're concerned about your kid, right? I think it's a fair kind of question to explore with them. Is this something that ever happens for you? Yes. It's like, wow, thank you for telling me. What's going on?
Yeah. It's not going to open up ideas to someone that hasn't thought about it. It's a myth, right?
No, that's not a thing. Yeah, you don't plant them, which is helpful. That's good to know, right?
What do you mean by encourage delay? I mean, I mean, like, this is a bad week for me, like, wait to have your meltdown next week.
Yeah.
I mean, isn't the goal to, like, flat out stop it? I mean, like, are you just kind of, like, buying them, yourself, more time in order to get them? Like, figure out how to get them the appropriate help?
Yeah, the encouraging delay is it's pretty provocative. I've literally said to people, I'm really hoping that you'll give me some time with you. 3 months. You can always kill yourself after that. Like literally, I'll say that to some people. And it shocks them too, but it's like, why would I do that though? It's like, because I'm being honest. I can't control you. I don't have a say in the decisions you make in your life. I would really like it if you'd wait, okay, and give me the opportunity to work with you.
I would never say that to my child.
Correct. Correct.
You know, like that would just.
Yeah, I've got a colleague in the United States who uses, she calls it the 3-day method, where she's like, here, you know, so tell you what, like, give yourself 3 days, and if you have any moment where it's positive, you have some positive experience, you have to start counting the clock again. The clock starts again, right? Essentially, like, let's wait for 3 days before you do anything, right? That's also pretty provocative. It's like, what happens if the person doesn't have any good experiences? It's like, well, what I'd like to believe is that because they're with you, right, and you're demonstrating the connection and you're instilling hope in them, right, on an ongoing basis, this is somebody you care about, okay, so that will help them to continue to delay, so to speak, right, and foster, you know, stronger connection, right? Yeah.
What if you have somebody that, like, let's say they say these things frequently in front of you,
Yeah.
and you've taken them to somebody and they're not serious about it.
Right.
But they say it all the time. Like,
Yeah.
it's like, you know, I hate that person. Like, you don't really hate the person, but like,
Yeah.
I'm just gonna kill myself because I can't deal with the boredom, I can't deal with, there's nothing to do in life, what's the point?
Yeah.
But then you take them to a professional person and they say,
It's not
yeah,
serious.
these are very serious.
Right, right. I'm with you. I do take that seriously, and I think it's important to sit the person down, right, and talk to them about it. Hey, what's going on? Right, right. I think that is the best premise to come from.
As a means to like get something.
Yeah, and so it'd be really nice to know what that is, right? Like, what are they trying to get? You have to talk to them. You have to talk to them, right? And hey, you don't want to talk now? That's fine. Like, I'd really love to know though, because I'd love to provide whatever it is that you need, right?
Aren't there cases of just plain hyperbole? Someone just say,
Maybe.
people use words.
They do.
I mean,
They do.
that doesn't-
Listen, to your point, people can walk around and yeah, you're right. To your point, like yeah, it can be hyperbole, but given the context, like what's the context, right? She's describing somebody, you know, that she knows, presumably, who that's just what they throw out. They get in a situation where they're stressed out and they're like, I can't handle this. I just want to kill myself. You know, like there's an element of distress there. It's not funny, right? Like, let's sit with the person, right? Yeah.
Related to these past questions, how can ADHD impact suicidal ideation, and how can it be responded to?
ADHD is on the list of risk factors. Listen, we know that people who tend to struggle, suffer with ADHD, right? It's also something that can make them more prone to emotion dysregulation, right? And so, you know, educating them about ADHD, you know, if they're age appropriate, and you can help them understand it. You know, again, meeting them, so to speak, where they are, right? Connecting with them, you know, and helping them deal with these emotions that come up. I have found that there's a lot of ADHD coaches here that are fantastic. So that can also be an area that you explore, right? Helping the person like deal with these, it could be social skills, it could be academic issues, emotional issues. But yeah, if ADHD is at the core, right, that's what you're noticing, that could be helpful, right? And talking to the person, you can identify that with them, right? Like, what's happening here? I can't focus. I can't get things done, right? So again, it's not coming from like, oh, it's got to be your ADHD. It's like, well, let's talk about this suicide thing that's coming up. I've had cases like this too, right? It turned out like the guy had ADHD and he couldn't manage it, and he was like, he couldn't succeed. He was like struggling. It was like getting him on a stimulant to help him focus, and a coach. So this is kind of a last step. Person won't talk to you. I don't want to talk to you. Okay, and I think this keeps coming up also. There is something in the literature that's really interesting that started in the late 60s. It's called caring contacts. And I think it is relevant in just families and among friends as well. The idea was that there were people who were actually discharged from a psychiatric facility for a suicide attempt. Okay, and this was in California. Jeremy Motto is his name. So what he did for these people, they had no interest in treatment. They didn't want to have anything to do with the hospital anymore. They didn't want to talk to anybody. They got released, and it was like, no, I'm not interested. I don't want any outpatient care. So what he did was he started sending letters to these people who didn't want any treatment. Very simple letters, but he called them caring contacts because literally what he wrote, and he had his staff write, was a personalized letter that would say, I know you were here in the hospital. I was just thinking about you. I hope you're doing well. Please feel free to reach out. And what was amazing, so that bottom line there, okay, this is over 5 years. Okay, the middle line, which is the white squares, okay, those are the people that didn't get letters. Right, so this is the rate of suicide that he found. Right, so it was about half the rate. Okay, I'll talk about the top line in a second, but this bottom line were those people who were getting letters. And the first 2 years is really critical because that's the highest risk period for people who get released from a hospital. Okay, this was just a letter that he sent to these people. Every month it started out, right, that he would send a caring contact. He even had a self-addressed envelope, right, that he sent in case they wanted to send a letter back. Okay, this has been expanded also. It really is the only randomized controlled trial for suicide intervention because you can't actually randomize people who are suicidal, right, to a no treatment group. That's not ethical, right? It's like, okay, you guys who are suicidal, you're going to get treatment, but you won't. We'll see if it works, right? Yeah, you can't do that. But this was a unique scenario, right? It was very interesting, just a letter, right? So it's been expanded now to like email, text message is interesting. I'm not sure how that works, but this is being expanded and explored, which is really interesting. But it really works. It's really interesting. It was a letter that was sent every month for about, I think it was the first year, it was every month. And then I think the second year was every other month. And then by the time they got to fourth and fifth years, it was like every 4 months, right? They were sending this letter. And then they ran out of funding. Okay. Very interesting. So the top line is actually, so to speak, the therapy group. That's concerning. It wasn't really doing much of anything for them. This was in the mid to late 60s, though. Again, when this data was being late 60s, 69 to 74 was the data collection. There was no such thing as a suicide-focused treatment then. It didn't exist. Okay. Remember, Edwin Schneidman came on the scene in about 1966. Okay, he created the American Association of Suicidality, right, in 1969, I think. Okay, so it just became a conversation that people were willing to have in research. Right, so these people didn't, in their defense, if you will, they didn't know what they were doing. Okay, but that is concerning. That's very interesting. Their rates were going up. They were significantly higher. Okay. Here are some resources, right? You can couple that with caring contacts as well. It's like, hey, I totally get you don't want to talk, no problem. Just want to let you know I care about you.
This is for the people who are suicidal.
Yeah. Yeah.
There is no organization for family members to help people who are suicidal.
So they have organizations in the United States, actually, right? Yeah, here in Israel, I haven't heard about that. You're right. You're right. But the truth is, I advocate for people to, if you use the internet, and I'm not advocating for the internet, but if you do, then, there are resources that you can connect to also in terms of social organizations, on Facebook, support groups for families who are struggling with this, right?
Another question regarding therapists.
Yeah.
As a family member, how are you supposed to know whether the therapist is helping or not? How do you find the right therapist? I
think interviewing them based on what we just discussed, right, is really key. I would like to think that from what I went through, you'd be able to have a sense of like, wait, what kinds of questions would I want to ask this therapist to understand, like, can this person really help my loved one? And like, what do you do? Right? What's your approach? Well, I know that it's always depression. Like, probably not the best therapist. Okay. What I have found that's very interesting is that even therapists that I've met who don't necessarily have official training in suicide-focused treatments, they're doing everything right. It's very interesting. It's like they actually know what they're doing. They don't have validation for it because they haven't gotten training, right? So they're a little doubtful, right? Like, wait, am I doing this right? I don't know. So I'll consult with them, and it's very interesting. So some of them will be like, wow, that's so great to know that I'm actually doing that, right? I'll add pieces in terms of official assessments and stuff like that, just in terms of their therapeutic skill. Okay, it's actually there. So there are people that you can find who are good, right? But I think using what we just went through, right, in terms of like identifying that person, right? I think that would be a good approach. Does that make sense? Yeah, we can talk to him. Contact information. Yeah.
Any other questions?
Here, 1 second. I'm going to take it back. I don't know.
We'll have the videos.
With the slides?
We'll insert the slides.
Yeah.
Is there an age group that is more prone to suicide? And the second question is, I think I know the answer, but it seems like men are more successful at suicide, but not necessarily because they attempt. Women attempt just as much, but men are just more successful at killing themselves.
There's some truth to what you're saying. Women actually do attempt about 3 to 4 times more than men. Men die more. Why?
Because they're more violent.
More violent. That's right. They use more lethal means. Right. Yeah.
Is there an age also?
So what we find is that in general, like I think it's like over age 34 is where we see the highest rates of suicide. Over 75 in Israel, I believe, is the highest rate, for suicide. I think that's right. No. Over 75, age 75, like elderly. That's where I think that's the data that I've seen. It's a good question. I don't know. So listen, when you're dealing, if you're dealing with, first of all, we see the greatest amount of variability in terms of health-related issues, right, in the elderly, right? So you can have people who are extremely healthy, right, and very fit, and people also who are bedridden, right? You don't find that with young people. That's very unusual, right? So a huge span in terms of like the quality of life, right? So you're dealing with, let's say you have a person who has some terrible disease, and they're bedridden, and they have a lot of pain, and they have allergies to medications, so they can't take them for pain, right? And they have trauma, right? And their marriage is falling apart. It's like, right? So it can just make things really, really tough, right? And I know also for myself in working with somebody like that, it is a lot more challenging, right? Because it's like there's a lot there. There's a lot going on.
If I'm not mistaken, the numbers that are most concerning,
Yeah.
that I can see, that the ages from 15 to 24 make up about 30% of the suicide attempts.
I don't think it's that high, but it is concerning. We do see an elevation in the rates. I know. But again, to the point that I was trying to harp on as well, like the thoughts and the attempts is really what's extremely concerning, because that really is the preemptive element that leads to ultimate death. Okay, so like somebody's thinking about it. That's what we know is a clear indicator, right, of risk. Right? So that's the person we have to address. Oh, they're not going to do it, and now they're fine. Like, no, that's not how it works. Right? They're thinking about it, and you need to take that seriously.
I think also our goal has to be not to just get them not to kill themselves, but to alleviate their suffering, because that's what
Yes.
they're getting.
Correct. That's right. That's exactly right. I'm with you.
Successful because we took away all their tools to kill themselves, and okay, now we're calm. There's some suffering.
Correct. That's right.
question is, this is what I'm hearing, is that actually these kids are at very high risk.
Right.
Because they jump into the, call it non-from whatever, like free lifestyle, right? And they don't fully fit in.
Hmm.
They don't fully get accepted by the Filani or whatever, right? And then they have already disconnected themselves from the community and sometimes family that were there for them in the past. And that's when they're so incredibly lonely.
Yep.
And then it's hard to reach out to them if they're like spiky, and especially if they're in their teenage years.
Yep.
So I really want to know, like, how do you, they don't talk about their, whatever it is they're feeling, at least not, you know, so much with, I don't know about everyone else, but, you know.
Yeah.
They don't come and share it so often with their parents, and they seem to be living their life, like they especially want to even show this, you know, I'm so happy with that decision I made. That's even like,
Yeah.
but, so how do you like enter that, you know, they even have this like really closed door. They don't want to be,
Yeah, it's like they don't want to connect, like you're saying.
because they want so much to prove that this decision they made is good.
Mhm.
Some of them are whatever, they made that decision and they are happily living their life, they're not suicidal or upset, but some of them are to a certain degree lonely.
Right.
They're
Right.
in between two worlds.
So I think there's two things that I think about as I'm hearing you talk. One is, well, that self piece that I was talking about earlier, right, where you're really looking to identify for yourself, like, wait, what's happening for me? What's making this difficult for me? Right? Let me work through that also, and then can I join this person, right? And essentially play with them, right? If it's a kid, right? Can I go play with them and just hang out?
How do you
Yeah.
like, just come and just talk about it?
Yeah, yeah, and I think what I'm trying to get at is that rather than worrying about how do I talk about the issue that I'm most concerned about, right? Can I slow down first? Can I slow down and just work on building this relationship with this person first, right? Just being there with them, however they are, right? Like, okay, let's say that, yeah, the person's become secular and they're involved in things that are not good for them, and you know, we would all agree, and you know, but it's like, well, yeah, but that's what they're doing. So can I just connect to them still? Can I work on that?
If there's a superficial connection,
Yeah.
there is a connection. It's not like there's
Correct.
there is a connection.
Right.
It's just very like, you know,
Right.
how's
Right.
the weather?
Yeah. Yeah. So that's why I was thinking to myself, like, wow, you know, what would it be like to foster some kind of interaction that involves like playing, right? Like there's something that you know that they like, right? They like doing. It's like, hey, can I accompany you? I love you know, you like whatever it is, video games or I don't know, just like being creative in that sense.
But if that exists,
Yeah.
there's family trips, there's fun times, everything's fun. Everything's like, you know, they'll even
Yeah.
come for Shabbos.
Yeah.
But like, then there's that, there's a certain level, I just don't know, as a parent, you're causing, you know, it's
Yeah.
like worrisome.
Mhm.
I'm hearing that the percentages of these children are high.
Mhm. I think the percentage,
That's all,
right?
it's true.
So the suffering side is high, right? The suffering side is high. We see that in the data, right? In terms of actual events, right, where people are actually killing themselves, right? That is, relatively speaking, it's extremely low, right?
Of the OTVs?
Of people who die, right, by suicide, right? Relatively speaking, is extremely low, right? That's why we talk about it in terms of this number out of 100,000 people, okay? But then, yeah, the people who are suffering, right? There's a lot of people like that, okay? And if they're with us and we're trying to figure out how to connect, so that it's a dynamic. It is a dynamic situation, okay? So it's something that you do have to explore, and hopefully, I would hope that some of these tools will like aid you in just navigating it, being creative. You can be in touch too. It's also okay. All right.
I'm sorry. I just want to say one little thing. You know, what we've been trying to do, at least over the last couple of weeks, is we've been building up situations, one over the other. The first part of what we were doing when we did the first week was the attunement of our children, being tuned into them and being understanding where they're holding at that moment in time. When we unfortunately sometimes make mistakes, not hearing, not understanding, not being aware, it can lead to other forms, whether it's mental illnesses, whether it's turning into addictions. The connection, whenever a child is feeling not heard, not seen, not felt, they'll tune into something else, which is what we spoke about last week with the addictions. And that's what we were talking about, how to help them through that specific moment in time of the addiction. Before we even got to suicide, there are many steps usually leading up to before a child, a person, an adult, anybody, before they even come to the conclusion, it's time to end my life. There's a lot of steps before that if we're tuned in correctly, we can preempt those suicidal ideology. We're here talking about tonight, well, what happens when we get to that last stage where they're talking about the suicide? Where we may, not on purpose and not by our fault by any means, did we miss the signs, did we miss the steps? But now we hear the kids scream, I just want to die, or I just want to kill myself. The child usually says these things. So the question is, all those questions that we heard before is, well, do you really mean it? And can you ask that child without being judgmental? Can you ask the child, well, did you really mean what you just said? And if so, let's talk about it. I'm very curious and I want to understand. Those are the tools I think we were trying to get here tonight, which we did very clearly. So it's a process, and it's a big circle and a big bubble that all these pieces to the puzzle unfortunately gets us to this place where the child is crying desperately, or any person, not just a child, somebody in the 30s and the 40s. We've seen it too many times. A father of 5 jumping off a roof of a house on a Shabbos morning. We don't know what was going through his mind, but there are signs and there are questions that we can ask. And once we see that these questions, that the person is responding to those questions, don't just let it slide. Those are the people that need help. They need continuous help. And if we can't give it to them, then you have to get for professional help. But think of it as a process that we can see early on, see the signs and understand them. And I think it's beyond the scope of the amount of time that we have on each evening. It's a very long process. But I think with all the tools that we heard tonight, these are questions, many of these questions could be asked earlier in stages, earlier on. So it's not about which group of people are more at risk versus other groups of people. I think that's beyond the scope of the time. But we can definitely talk about it. But yes, kids who are off the derech, there's a reason they went off the derech. First, let's find out why they went off the derech, and we can work with them. A child with ADHD, if they're not being heard and felt and seen and soothed, could turn into other things. And that goes with any bipolar, schizophrenia. The idea is behind the scenes. We want to avoid getting to this place of suicide. Tuning into them. Sorry if but what we learned here, I think, tonight, and we saw so much and so much information, it takes time to digest it. And Bezrat Hashem, especially for everybody that was here, especially for the, things, you'll have access to the videos to be able to see it again in case you miss something. And you'll also have the opportunity to send in questions and ask and be involved. No one's here being left alone to say, now go figure it out. That's what we're here for. We're here to help answer the questions. We're here to be on your side because as Dr. Siegelman said, very, very, so important, your self-care. Self-care is you getting the attention that you need so you can be there for someone else in their needs. If you're not being taken care of on your own, then there's no way you can sit next to somebody and help them. Because you're not going to be able to know what to say and what to do, and you're going to be frazzled, and the person's going to think that you just don't care about them. Sorry for intervening. I just wanted to clarify at least what we've been trying to say for the last couple of weeks, and not make anybody feel that, this is one piece and everything's all by itself. Being understanding from the get-go, we can avoid getting to the suicide ideology. And suicide ideology doesn't just come overnight. It's a process. It's a step. It could take some, I think you mentioned it, it's very rare that somebody just wakes up one morning and says, I'm done. There's usually a process that the person goes through. And when they go through that process, we can be there and catch it somewhere along the line. Just tuning in and asking the right questions. And most importantly, not being afraid to ask the right questions. And when I say don't be afraid, it means like, I'm going to ask you this one time and one time only, are you suicidal? No, that's not what I meant. But it's a conversation to have with your child, with a friend, and talk about it. If you know they're going through a hard time, have a little conversation, build up so they trust you. And you can even ask that question on the past, just like, have you ever thought about hurting yourself? They'll actually think about it and they'll answer you. Got anything else you want to say? Nope.
Thanks.
So the first responder toolkit that you gave us is basically focusing around connection. And a lot of the things, you said there's a lot of risk factors, but it seems to me that if you add them up, you might end up seeing that loneliness, isolation plays an outsized role in people who are.
It's a major component. It's a major issue. And we definitely want to reduce isolation. We don't want people to be alone when they're suffering. Right?
A kid who feels out of place because he's off the derech, or an older person who is suffering by himself in a hospital and he has no family to take care of him.
Correct.
Both